Our next speaker is Anne Single from the Patient Voice Initiative, an association that works towards improving the patient voice in the Australian health system. Anne has more than 20 years' experience in developing policy and practice in patient involvement in health technology assessment, or HTA. She is chair of the HTA International Interest Group for Patient and Citizen Involvement in HTA and has been proposed as a consumer representative on the Australian Government's HTA review. Anne will be speaking to us today about valuing working with patients in HTA. Welcome, Anne.
Thank you. Gosh, that picture's terrific. What can I say? COVID's been difficult for everyone, and apparently a lot more difficult up in Queensland than in southern states. Thank you to Rare Cancers and Canteen for the opportunity to speak today. Can I acknowledge the Ngunnawal people and pay my respects to their elders past, present and emerging. And I will flick my speaker on. As Karen mentioned, I'm with Patient Voice Initiative and I'm also involved in this international interest group. I just want to briefly say something about that. The Patient Voice Initiative is a multi-stakeholder group, but it's led by our chair, Jessica Bean. And Jessica can't be with us today, and for once I'm super delighted that she can't be with us. Usually I'm much happier for her to take these speaking engagements, but some of you may know Jessica is expecting a baby in October. Jessica is one of more than 2,000 people who've received Trikafta for cystic fibrosis, who are having babies. And there's an unintended consequence, isn't it? So when Jessica's back on deck, she will share that story with you, but I just want to acknowledge it today because we're thinking about consequences that we value. And the other thing I want to say about that international group is in that group, we have over 300 people in 43 countries around the world. They come from all different stakeholders, all different disciplines, and they're all there because they believe that patient involvement in HTA makes a difference to the quality of of HTA. And so they work on methodologies and on approaches so that we can do this well. Because one of the things we also know about patient involvement in health technology assessment is it can be a burden. So we need to do it better. So I wanted to talk today about valuing working with with patients in health technology assessment. And I know we've been talking about this thing, HTA, health technology assessment, all morning. But I would be very surprised if there are not people in the audience who've never heard this strange term before. There are others who know a great deal more than I will ever know in this space. But I just wanted to take a moment to sit back on this term and to think about what health technology assessment is, because I think it gives us ideas about what health technology assessment can be to our community. And so health technology assessment, you might know, it came out of the US in the 70s, but a few years ago, an international group defined it again. This happens from time to time. And what that definition in front of you does, it highlights that it's a multidisciplinary process, so it brings in all kinds of knowledge. It uses explicit methods, so robust methods for bringing that in. And really what it's trying to do is determine the value of medicines and other health technologies. This term health technology you hear around today, understand that can be anything from a Band-Aid to a blood product. It could be the latest immunotherapy, or it could be an exercise program. It's really any health intervention for prevention, diagnosis or treatment. I know some of you know this well, but we're about to, we hope, have an HTA review. And it's really important to me that we all understand what this thing is, because it's just 3 letters, but gosh, it's important. And I'd like to say it's a lot sexier than some of my colleagues suggest. So it's there to inform decision making. It's there to get that equitable, efficient and high quality health system. But I've a little cheekily depicted it as a box, because it's done in more than 30 countries around the world, and it's always a little bit different. And different countries put different emphasis and they do things slightly differently. So that box can contain all different manner of things. And I've put it there as a bit of a closed box, because I think for many of us it's really hard to understand what's going on in health technology assessment. And that's why we're grateful when someone like Andrew comes to speak to us about what's happening, how it's working, because it's really hard to see sometimes. So as Andrew said, it's really a way of determining value, and it does that by comparing. So I'm not going to keep using the word health technology for the next 15 minutes. I'm going to drop back and say medicines, but as I do that, I just want to acknowledge that the medical services and the consideration of how that's done at MSAC is every bit as important as considering how things are done at PBAC. So what it's doing is it's comparing two medicines, and it's using good quality evidence. So it's looking at randomized controlled trials, and then it's doing economic analysis. And we've talked about why we put a dollar figure on that. And for me, the reason we put a dollar figure on it is because it gives us units that you can compare then. But it could be something else. So it just needs someone to think about that, someone smarter than me. So what goes into that box? As Andrew alluded to, there's a lot that goes in the box, because what it's trying to think about in health technology assessment is what are the consequences of this. And we've heard patients this morning and their families talk very eloquently about some of those consequences. And what you see around the world is that sometimes these consequences feature more strongly in the consideration, sometimes not at all. I would have said that always thinking about the wider implications for the patients, relatives, caregivers and the population is critical. And yet I've had some people explain to me how that just naturally flows from the data. Not in Australia, I should say. So the issue then is that determining value, as Andrew spoke about, it depends on your perspective. And so the international definition has picked up on that idea and said, you know, that it depends who is involved in health technology, the sort of value you might determine. And why is that? Well, health technology assessment begins by asking questions. And depending who you ask different questions about a medicine. So if you're a patient, you're going to ask different questions, say, to your clinician. Maybe there's a bit of crossover, but there's some that your clinician's certainly not asking. And then if you're a health researcher, you're asking different questions again. And so then to answer your questions, you're going to need different evidence or information. And that means that we determine different values according to our perspectives. So who asks the questions and what evidence we use to answer them becomes really important. And over more than 20 years of patients being involved in health technology assessment here in Australia and around the world, we've learnt a lot about what's not sitting in that evidence base. And I'd just like to acknowledge the many thousands of patients and patients associations around the world who've taught us these things. So we know that the evidence is unlikely to capture this sort of information. Firstly, are they the outcomes that matter the most? Is the comparator appropriate? What does quality of life really mean? You know, you see these terms like fatigue. Does it mean that, you need to have a bit of a lie-in in the morning? Or does it mean you actually can't prepare meals for yourself or drive to work? So what is the real-world implication of quality of life? Local variation in the provision of services. This is one that gets highlighted in every study, because around the world what people think exists in a health service and what patients actually receive are quite different things. And patients are really great at highlighting this. The pathways to access and what that might mean. Endless information we depend on patients for, and it comes with a burden for patients to provide this in their communities. It's essential for us to understand the value of those health technologies. One of the problems, though, is we don't hear about it often till quite late in the life cycle. So what I've attempted to do here depict the life cycle of a medicine. So it might begin with research and development. It then may go through a process to be approved to be sold in Australia, and then it will come in at reimbursement for health technology assessment. Some of these other areas are called health technology assessment too, but let's focus on reimbursement, because that's what we're interested in today. And one of the issues is that in a lot of cases you can come all the way through to health technology assessment without this information being captured and documented about what matters most to patients. And even when it comes into health technology assessment, you go all the way through evaluation without this being explicit. So you're doing your economic analysis without knowing these things. And then what people do at appraisal is they have to now take those numbers and then with this wider context they've learnt from patients, make sense of it. Now I know I've simplified that a bit, but that's the challenge here. We've done our economic analysis before we've understood the patients. I should say it's changing around the world, and some of you may work for companies that are increasingly involving patients earlier in research and development. But what I would say is we still get an awful lot of evidence through where we either don't know whether patients were involved in it or they weren't involved in it. So we can't make an informed decision. But there are some great examples. For example, the European Initiative paradigm, which was multiple companies, multiple patient associations, multiple HTA bodies, including the Canadian one snuck in pretending to be European. And what they did was they worked together to develop tools and guidance about how you get patients effectively working with you during R&D and also through that early dialogue process that exists in some systems. We talked about bringing topics and proposing topics. A lot of HTA bodies have tried this, and it's difficult because forming research questions can be difficult. But I'm pulling out IQWiG in Germany there because they've done a lot of work to make this much, much more simple. And so they get 5 topics a year from their community. They're usually from patient communities, highlighting a need. And then there's a panel which includes patient communities to prioritise those questions. So their HTA, rather than responding always to the technologies coming through, is thinking, where is the patient need? Now let's ask the question. And many of you will know NICE in England. NICE is one of the bodies where they bring in people, patient groups earlier into the process, usually before phase 3 trials, sometimes before phase 2. And they start scoping the sort of assessment they will do. So talking to the patient population about the population, the intervention, the comparator, the outcomes, what's going to matter here, what will good evidence look like in this space. I made notes today. How we've timed, great. So quickly, a few other examples. Wales is really new in this area. It's a non-medicines HTA body. They decided, let's create our patient involvement processes with our community. So what they're doing is each time they do an assessment, they've got patient community members in a group, and they've got patient expert people, and they work out what is going to be the best way to engage with this community when we do this assessment. And from each assessment, they're learning and they're refining the way they work as an organisation. In Scotland, which had patient involvement in the Scottish Medicines Consortium from the moment it started, after a while, patients said, you know what, we're a little bit tired of being your input. We don't always want to answer your questions. We actually want to have partnership with you. This belongs to us too. And so they introduced the idea of patient group partners, where patient associations sign up and become partners, and then they have an advisory committee above it. And that advisory committee, its remit was to improve patient involvement processes. But over the years, trust and confidence in each other has grown. And so now they've been involved in much more than patient involvement processes. They've been involved, I would say, in setting the rules for HTA. So they help develop the ultra-orphan process, and they helped develop the criteria for what ultra-orphan would be. And even in COVID, SMC had to stop doing HTA, Scottish Medicines Consortium had to stop doing health technology assessment, and it was the patient partners who helped them work out how to prioritise and ramp up again. And you can see this influence on starting to shape how we do HTA over in France as well. So it was the Federation of Patient Associations there that helped with, that worked together with the HTA body to define their new early access to medicines process. And so they said what was in, what was out, how are we going to do this, how are we going to meet our needs. And the final one, which I won't go into in depth, but it's a process they're working on in Europe for being more explicit about the methods and making judgments before you start the HTA about the values you're going to use when you're doing the HTA, and then making sure that that is clear. And of course, the real trick is when your values are competing and having the dialogue with stakeholders about those competing values. So with all this great work going, when I went to the annual meeting last June, that's my holiday snap there, you would think that I would be really encouraged. And yet I took a day off after annual meeting, and I have to say I felt pretty flat. And that was for a number of reasons. One of the reasons I think was really that we hear a lot of talk, and we heard a lot of talk there, about HTA not being a barrier to innovation, but HTA being a steward or a coach that brings innovation into our health system. And so we talked a lot about learning with people. And I guess I felt discouraged because I still think we keep patients a little bit at arm's length on this. We keep patient communities at arm's length on this. We're happy to have their input. We're happy when they address the questions we've got that we haven't got answers to. But I'm not sure that we're yet feeling really comfortable working with patients on how we're doing health technology assessment. And I think if we're to tackle some of these really complicated questions about how we understand value and how we have processes that do that, we should be involving patient communities to problem solve with us. And excuse me for this long quote, but I was thinking, gosh, you know, it's just like Pascal Lou's work. Now, I'm not an academic, and those of you who are academics in the audience will know that straight away. But Pascal is a French-Canadian academic, and she's been incredibly thoughtful about this area for many years. In fact, I was incredibly disheartened when I looked up this quote to find, actually that was 2006, she said that. So excuse some of the language there. She talks about lay. It's 2006, so it's before people realise patients are experts. So just ignore that bit. And she also talks about public, and Pascal would be the first to say patients are not public now. But in 2006, we talked a little different. You know, we barely had mobile phones. But what I wanted to bring out in that quote is she talked about this problem of trying to make patients fit into our structures. And we see that, you know, we write our written submission and we put it in the computer and it flows in the machinery of HTA. And really what we want is structures where we can learn with patients. And we see that informally, even here in Australia. I couldn't, many of you will know, you know, Joe or Sally, they're on the phone, they're chatting through the issues. And that's really what she says is required. But she says something else is required. She says that what she really wants is deliberative processes, so dialogue that's really well informed, where we can explore the public good that we want to achieve in all of this. And so she says that what we need is continuous and sustained discussion, not one-off public consultations, but places where we can have dialogue like we are today and make sense of this and find shared ways of really exploring this area. And so why, if she said that in 2006, do I think it's still relevant to bring up today? I think there is still a little bit of reluctance here, and I think we don't always talk about it, and I think it's that tension between science and participation. I think we like to think that data is pure, that it's not value-laden, and that it's neutral, and that if we bring the patients in on that, that we might lose some of that. I love robust science, that's why I'm in this space. But I don't think science is neutral, and that gives me an excuse to share another pair of academics who come out of Aberdeen, Vicky Entwistle and Stacey Carter, who've been really thoughtful about this space for a long time. And I just wanted to end by showing you this quote. They wrote this 5 years ago. They said, "It's important to recognise that health technology assessment is a value-laden enterprise whether or not the patients are involved. We're not the threat to health technology assessment. Highlighting this could be one of the most important contributions and indeed strategies of the patient involvement movement. Once the value-laden nature of HTA is acknowledged, the field of values that is recognised as relevant can be expanded, and the need to attend to the perspectives of patients and other stakeholders should be more apparent." So with that, I'd just like to leave you with the thought, there is a way of involving that is about being input, but if we're going to resolve some of these serious challenges in how we value new health technologies, we need partnership with patients, because in those communities is an enormous amount of knowledge that can help us solve these problems. Thank you.